For those of you who don't know me, I'm Janet Gardner-Medwin, and I am a paediatric rheumatologist. So I'm not an eye specialist, although I'm talking about eye problems today. And I've really focused this talk on uveitis for children who have a diagnosis of arthritis, of JIA. But if there are any parents here whose children have uveitis for another reason, there's a lot of general information about uveitis in here, and I hope that there'll be things that you can get out of it. And I'm really happy to take your questions at the end about that. So I think eyes, there's something about eyes, they're so precious, aren't they? They're just, my slide's not going to change, all that be shame. Eyes are just so terribly precious, and we need them. They're the window to the soul, but they're also so important for what we do. And I think when we tell you that children can get inflammation in their eyes, I think that is sometimes a really scary moment for parents. I put up this picture of having a bit of a nightmare. I think, you know, sometimes when you first come to the clinic, I think this is how parents are feeling. I put up a little kind of sequence about how I sometimes feel that first appointment goes for parents. You know, you come along with your child with maybe a swollen knee, and you're hoping it's just going to be a little sprain or a little something that'll get better. And the first thing we tell you is that this is arthritis, and that's a big shock. And then we start talking about complex treatments and blood tests and injections and all these complicated things. We think we're really clever because we introduce you to a whole host of new people, and it's really quite overwhelming, I think. New words, a whole new language. And then we hit with the news that it may not just be the joint, they could get this thing called uveitis. And then people start talking about eye damage. And then if you've got a little one, they often won't sit for the test, and you go home with a child with a swollen joint still and worried about their eyes. And all we've done is build on your anxiety, I think. So I don't know whether that rings bells about how your first appointment was and how scary it was. But what I'm really hoping is that I can address some of those worries and nightmares today. And as I work my way through this, reassure you that we do have your child's best interests at heart and where we're going with this. So this talk is for the young people and parents. I think sometimes it's easier to ask questions in a talk than it is in a clinic. In a clinic, it's very definitely about your child. In a talk like this, it can be a more general question, and sometimes it's easier for me to answer them. I can answer it very generally, and it doesn't necessarily have to be the right thing for the child in front of me. I hope we can sort of, any questions you have or worries or concerns, or have a piece of paper with you now and write them down, and we'll address them at the end. But please ask. So I think the first thing about having a child with arthritis is that you become part of the team. The team seems huge. There are lots of people that you may not have even have met. And right in the centre it is your child, lost amongst this crowd of professionals and other people. But the other people who are really central to the team are you. You are the key team members to work with us and be the facilitators for your child, be the voice for your child if that's hard for them, and generally to be the people to support your child. I'm going to click admit for a few of these folks who are just coming in. If there's one, if you're a parent with a very newly diagnosed child and life is really hard at the moment, I think there's one other key person that is really your go-to person, and that is the main nurse. Their job is there to support parents, to answer their questions, and have time for them. So I think the nurse can be an absolutely key person for you to know. So there we are, your child's coming to a clinic somewhere in Scotland, and there are all these people that you've been told are going to be contributing to their care. And it really doesn't matter now where you are in Scotland. We are all joined up with a network. The paediatric rheumatology consultants do clinics in all the different places, and we meet families from all those places. And in each centre, there will also be a paediatrician who is there to support you, and their team, nurse, physio, and of course an eye doctor. And then we are part of a larger team. So we belong to the British Society of Paediatric and Adolescent Rheumatology. And some of these signs that I'm putting up are quite good websites to look at if you want some places to look for good quality information that's straightforward and honest. So some of these will be quite useful places to look. And then, of course, we belong to the wider world as well. So I put in a picture of Europe because we belong to the PRESS, the Paediatric Rheumatology European Society, but there are also the American Academy of Paediatrics, the Canadian Paediatric Society, and indeed increasingly South America and Eurasia. We are all joining together and sharing our knowledge, sharing research. And I think COVID has certainly taught the general public what clinicians have known for a long time, that medical knowledge is just so quick these days. So if you think about the pandemic, started back in December 19, we knew the sequence of coronavirus by January, and we had a first prototype vaccines by March, and then we had to do clinical trials. Wow, that's quick. So medical knowledge is doubling all the time. So our job, one of our jobs, is to get that medical knowledge from wherever it's coming in the world to you in the clinic seamlessly and without it being a burden for you all. So the next thing I just wanted to say as a general thing to parents, particularly at the start of the journey with a child with a new diagnosis of JIA or a new diagnosis of uveitis, is that it is natural to feel guilty that something has happened to your child, an illness has happened to your child. And I think there is nothing that you have done or you have admitted to do that has caused your child to have arthritis or indeed uveitis. And I think the best place to leave that guilt is in the consultation room, and to be really positive about things, and let's see what we can do to improve things. So I don't want any of you feeling that you have done anything to cause this for your child. That is not true. There are many reasons why these things happen. They're multifactorial, and indeed the medical world doesn't entirely understand what makes these things happen. And so all this guilt is just a burden to carry and is very wearying and not particularly useful. So instead of suffering the guilt, I think one of the things I would like you to think that you can do is ask for help. And it doesn't have to be medical stuff. Do you know, I think that there's a lot of feeling that there has to be a medical question behind things. But it breaks my heart when a child who comes to the clinic who was really looking forward to something at school, and mum said, no, the medical appointment's more important. Now, if you're worried and your child's ill, of course you want to keep that appointment. But if we can move it, we can do that. So contact us. Do you know, there are some things, it's really important for your children to have a normal life, and normal life is doing the things that are important as well as the medical things. But tell us if the treatment's going badly. Do you know, if you're struggling with eye drops of uveitis, or one lovely teenager was injecting her medication into her teddy and didn't want to say, I don't like it. Actually, we'd much rather know she didn't like it and we could change it. And then we have had some families who have really had a terrible time and made really big decisions, like changing jobs or giving up jobs, and have been struggling with anxiety and really getting worried about things. So please tell us. You're not the first, but I think sometimes you feel that that's not what a medical appointment is about. It's about the medicine, and that's not true. It's about the whole family and the whole context. So I just wanted to put some of those general things up before I go on to talk about uveitis. Another thing I would really like you to do is share our expectations. We have very high expectations for children with arthritis and uveitis these days. We are aiming for perfection, and we most often achieve that. That is the best, that is the normal outcome we have. We have good joints coming out of it, and we have perfect vision coming out of it. And so one of the things that, you know, doctors are very bad at is telling you the bad news when you come to clinic at the beginning, and not actually that many, many children are doing extremely well. It's not true for everybody, but we will tell you. We will tell you if we think things aren't going as well or going to be more difficult. And if we're not saying anything, it's probably that our expectations are high. I put in this little quote. When I was a senior trainee, which is a dreadfully long time ago now, a professor of adult rheumatology said to me, the problem with you paediatricians is that you teach your patients to expect too much. Well, woohoo, that's an achievement as far as I'm concerned. I want those children that I see to go to the adult service if they do need ongoing care when they get to that point, with high expectations, and demand the quality of care that they deserve when they get there. So I'm very proud of that quote, because that makes me feel as if we did the right things. Okay, the other thing to say is to look after yourselves as a family. A new diagnosis like this is incredibly stressful. Marriages can get into trouble. Other children can be neglected in the family. You need to look after the whole family, and you need to tell us if that's not working, or if there's one member of the family who is getting very distressed. Dads often feel they have to carry the burden and that they're not allowed to be upset and unhappy about it. And they are allowed to have their private time to say that this is difficult for them too. Right, how does the journey go after a new diagnosis? I'm just doing a little bit of new diagnosis because I'm aware that many of the people that join may be at the beginning of this journey. And I think some of the things I'm going to go on and say may never happen to them. And so I think it's important that we just put it in a bit of a context to start with. When you first come to the hospital, I think it can be overwhelming. And for some families, I think it's very natural to say that they'll just do whatever they're told in those first few appointments, and then go away and worry that they maybe should have taken more part of the decision. Things change over time. Your needs change over time, from being a parent where this is completely new to being a really experienced member of the team. The other thing is that you may ask us what the outcome for eyes or joints is going to be, and you'll get a slightly woolly answer because we can't actually tell you at the beginning. But I do often say that the first year often is very typical, and it will tell us if things just all go into remission and your child's completely well and things are going well, that's good. If it takes a bit longer, then it may be that we're going to have a slightly more difficult journey. So you can ask, about it, but you may not get a completely straight answer right at the beginning, because we honestly can't, we haven't got tests that tell us what the future holds. The other thing, of course, is that children grow and change, and the needs of a toddler in the clinic is very different from the needs of a 4-year-old or a 6-year-old or an 8-year-old. We are paediatricians. We hope that our service adapts to the age of the child in front of us, and indeed the needs of the patient the parents in front of us. So, you may feel that, at the beginning of your journey, you're just happy to take any advice you're given. But as time goes on, you may want to take a much more active part in those decisions. And some people want to have all the information at the beginning and make all the decisions, and that's fine. And it will change, and that's good too. The other thing to say is that particularly in the bigger centres where there's a choice of staff, you may particularly get on with one nurse or one doctor. And really at the beginning of your journey, that's great if there's a bit of consistency, and you can ask if you can do that. And we can try and help you. So, try and think what matters for your child. If it's that one particular nurse is brilliant at taking bloods and brilliant with your child, then you can see if you can ask if when they're next on duty, and whether you can plan your next blood test for a time when they're there. The other thing we are terrible at, and you must call me out if I do this today, is that we have been taught to speak medicine, and you don't speak medicine. And so we have this huge language barrier, and I will endeavour not to speak medicine today and just to explain things clearly. But it is very easy to slip into this language, and it's a very bad habit that we all have. So please tell us. If you haven't understood something, that's not you, that's us. We should be capable of explaining in a way that you understand. I think there's a few more bits of good news. The first thing is that we have no secrets from you. I think a lot of parents think that we aren't telling you the full story, and that there's somehow some bad news that we're not breaking to you. That's absolutely not true. The worst fears are usually in your mind, usually at 3 o'clock in the morning, and we will answer any of your questions honestly, and that includes telling you the worst outcome if you want to know that, or the best, the range of scenarios that are likely to happen. And nor is there anything too stupid. That nagging question that's keeping you awake at night, ask it. The answers are probably significantly nicer than your imagination. We have very high expectations for our children, and we are very lucky in Scotland. In England, A number of the treatments have to be applied for on a named basis for each child, and that takes time and delay. That is not true in Scotland. If we need a drug, we can give it to your child. There are no restrictions on what we do. So we're in a very, very privileged situation here. So I think there are some positive headlines, and I'm going to go on and talk a little bit about uveitis. And I thought I'd put a few uveitis headlines up at the start, so that when I'm talking about the more difficult areas, you already know some of the better headlines. I am passionate about good eye outcomes. And so we care as much about a good outcome from your child's vision as you. I think it's sometimes difficult in a busy clinic to understand that, but we really are aiming for and usually achieve perfect vision. The medicines we have are really good. They really do treat this disease well. They don't cure it. They don't make it go away forever, but they do control it beautifully so that we have a normal eye that's doing normal things, is growing, developing, seeing as it should do. And this last sentence maybe needs a bit of explanation. If a child gets inflammation in their eye first, they can come to us with some damage, or if there's a delay to getting a diagnosis, they can have had some damage there, and you would know that right from the beginning. But auditing our outcomes in the last decade, in fact, it's a little bit more than a decade now, we have not lost any further vision than had happened right at the beginning, because we've been able to have access to these medications. So those children who've been taken these medicines have done very well indeed. So I'm going to crack on with uveitis now and explain what uveitis is. I'm then going to talk a little bit, because I'm hoping that most of you are here with a child with you with JIA, about the different types of JIA and how that affects the risk of getting uveitis. If your child is a newly diagnosed child with JIA, then one of our important jobs is to look very carefully and pick up the uveitis early. Early treatment is the key for both arthritis and uveitis to having it do well, having a really good outcome. I'm going to talk a little bit about treatment when it happens, and then how we do expect things to go, and how you can help will be themes that I will be touching on as I go through the talk. So what is uveitis? It's a terrible medical name. So the itis bit means inflammation. And you know that from lots of common things that you've probably heard people saying: appendicitis, laryngitis, conjunctivitis. Your children may have had conjunctivitis in the past. So medicine names the body part and then puts itis on it to tell us that it's inflamed. The other obvious one for you is arthritis. So that's an inflamed joint. So uveitis, the word uvea means grape in Greek. And for some bizarre reason, doctors still insist on speaking Greek. It's a mad thing to do. We should speak English. But they thought that the eye looked a bit like a grape. And so they called it the uveal tract, or the uveal. And it's this lining of the inside of the eye right round into the front of the eye. Oops, sorry, I must have touched a button there. And that's the bit that becomes inflamed, very much in the same way as the lining of the joint becomes inflamed in arthritis. And the bit of the eye that becomes inflamed can be different in different children. So most commonly in children with JIA, it's at the front of the eye, so we call that anterior uveitis. Intermediate uveitis really isn't very common in JIA. It's associated with other conditions, but much less commonly, but the bit we really worry about for vision is when it affects the back of the eye, because the back of the eye with the retina there is a very sensitive little membrane, and you really don't want that to be inflamed for a long time because it can be damaged. Very rarely it will affect the whole eye so that all of these areas are inflamed, but that's much less common. So this is taken from a paper showing that in young people, so children up to the age of 15, and it's quite a small sample, but you can see that the front of the eye was by far and away the most common site to be affected, and the back of the eye and panuveitis happen, but they're not quite so common. And that's a bit different from adults who get uveitis. So GPs and high street opticians are much more comfortable seeing adults with uveitis, and so this is a group of patients that they're slightly less commonly seeing. So I put up that picture of the eye, and I didn't really explain the different parts of the eye. So I'm just going to think a little bit about that. So if we start with the tears over the outside of the eye, we have the cornea, which is this beautiful, clear, glass clear part of the eye at the front that protects it. Behind it, we have the hole, the pupil that we all know, and the coloured part of the eye, the iris. So in this child, a beautiful brown, beautiful sort of greeny brown colour of the eye. And now those are the bits that you can see at the front. Oh, I'm sorry, let me go back. The white part of the eye here is called the sclera, and that doesn't usually get involved with uveitis in children. Sitting in behind the eye is a lens, and your eye is a brilliant bit of kit with light coming in. And what it does is the lens is contracted by little muscles on either side, and it focuses the picture on the back of your eye. And that's why people like me have to wear glasses as we get old, because the lens isn't as flexible, and so we find it harder and harder to get a really good picture on the back. And you've seen people as they get older holding books further and further away from them because these muscles aren't working well. But in children, they work beautifully. And then at the back, we have the retina. And most importantly, we have this bit here. And as you're looking at these slides, you will see that the very center of your vision is all really clear and is a beautiful picture, but this, you can see at the sides, but it's not the focus of your vision. And it's this macula right in the middle that is the really key point to having good vision. And the last thing to say is that the eye needs blood supply, and it needs a nerve supply, and that all comes in through this area here. So those are the structure of the eye, and I'll come back to some of those as we're going through and talk about them. There's also fluid circulating around in the eye in exactly the same way as it circulates around in the joint. And it is constantly turning over and being cleaned, and it drains out of drainage holes in the eye at the back into the bloodstream. So why on earth do children get eye problems when they've got joint problems? Well, we believe there isn't particularly high quality research in this area, but we believe that there are shared proteins between the eyes and the joints. And I've got some silly little videos to just show you a little bit about why we think that might be. So if you look at this lovely chameleon with his eyes moving around, you can see that that looks very much like a joint. And this is an artificial ball and socket joint. And as an ophthalmologist said to me once, it's obvious why they get uveitis, because the eye is just another ball and socket joint. And just like a joint, it has very similar tissues in it. I've already talked about it having fluid in it and a lining that is very delicate and is the part that becomes inflamed. And all of that's very similar to the joint. So we think there are real similarities between the structure of an eye and the structure of a joint. So, how many children get uveitis? Most of the literature says about a 1 in 10 chance, a 10% risk. I have put up some information here about a little audit I did ages ago. So I was a new consultant in 2004, and we looked back across all the children who were in the service. And of all the children with arthritis, 25% of them had uveitis, so quite a high proportion. We saw some children with different types of eye involvement that had nothing to do with JIA, and we still see those today. A much more recent audit shows that the number of children with uveitis has fallen. A smaller proportion of children with arthritis get uveitis, and I'm going to tell you why I think we're seeing less uveitis as time goes on in a minute. And so roughly half of our service is JIA associated uveitis now, and the other are children who have uveitis for completely different reasons. And we still look after them because we have these fabulous nurses who are very good at the drugs for treating uveitis, and we share that care with our ophthalmology colleagues. So if you're chatting to someone in a waiting room, you may discover that they don't have JIA. So why on earth should the incidence or the number of children with arthritis who get uveitis be falling? you can see here, so these are the numbers shown to you. So here we had about 100 children in 2004 with arthritis, of whom 28 had uveitis. But in 2018, we looked at 209 and only 20 of them ever got uveitis in the time we followed them. And we think that's because we are treating the arthritis with drugs that are also treating the uveitis, and so it never happens. The treatment for the arthritis is preventing the uveitis ever happening in our children. So the numbers have dropped. So the blue numbers are the numbers we saw in the past, and the red numbers are the numbers we're seeing now. So it's less common to get uveitis now because of the medicines that we are using already to treat arthritis. One of the other things you can see, these are months as they go by. So this is 60 months, which is 5 years and longer. And you can see that most of uveitis, if it is going to happen, presents very early on in the first, either the first visit or the first year or so of the child's time after they've had their arthritis diagnosis. But actually, we're probably seeing more uveitis as a proportion much later, and we think that's probably because we're stopping the medicines, and then the uveitis is appearing when we've stopped the medicine. So it was hiding away and comes later. But still, it never reaches the kind of numbers that we were seeing, the kind of proportion of numbers that we were seeing before we tried treatment. So we're probably stopping some children getting it ever. So I think there's a very positive effect of early treatment for arthritis. So thinking about the type of arthritis your child has and whether that alters their risk of uveitis, and indeed their age. And the age that children get uveitis goes very well with the pattern of arthritis that they have. So this rather busy slide is just a summary of all the different types. I don't know whether you guys have still got the little tab at the top there. Trying to get rid of it and hide it. Never mind. I hope that's not interfering too much with you seeing the slides. But the different types of arthritis have been defined really quite a long time ago now. They've been revised slightly, but it's small changes in the words. And it was 1997 that the fundamental change to the classification happened. It was done on clinical experience. And next time we change it, we will really understand this at a genetic level, and we will be doing it at a genetic level and an immunological level. But we are still using it done as clinicians' observation, based on clinicians' observations. And actually, they've been really good, and they have really helped us to understand the risks of different things, including uveitis. So I'm going to go through each of these in turn to talk a little bit about them. Again, we have persisted in speaking Greek instead of anything more useful like English. So oligoarthritis. Oligoarthritis means few joints, very few joints have arthritis. And this is the commonest pattern of children presenting with arthritis that we have. It makes up 60% of the children coming to our clinics with JIA. And like this picture of this gorgeous little girl with the blonde hair, which I've had as a slide now for a very long time. And if you go hunting on the internet, she's on there. She comes from a consultant in Canada from years and years ago, but she's really a very typical age to develop her swollen knee that you can see here. There's nothing wrong with her wrist. You can see there's a grown-up's thumb here. She's just reaching out to take their hand. So she's just got arthritis in this knee. And this is the age, so late sort of through nursery and the early years of primary school, many of the children with oligoarthritis are presenting. That's the kind of peak time. And often it will be a knee as the first joint, most commonly a single knee. And these children are a group that sometimes have a difficult journey to get a diagnosis. It's actually harder for doctors to diagnose arthritis when there's just one joint that's involved, because there's lots of things that can affect one joint. And so often, trauma or, something else going on with the knee pass through doctors' brains before they finally get the right diagnosis. So sometimes these children have had a little bit of delay in their diagnosis. So these are the children, they're very young, and they sometimes had a difficult journey. And these are the children we are really very, very keen to see the back of their eyes and make sure that they haven't got uveitis and it hasn't been grumbling on. These children with oligoarthritis fall into two groups. those children with persistent joints who never get more than 4 joints in their ever, that's the maximum they ever get, they have about a 1 in 3, a 30% risk of uveitis. So that's a high risk. You can see why we're keen to look in these eyes. But the committee meeting that did the original classification recognized that some of these children come with a knee and then a different joint, maybe not the other knee, and they gain these joints over time. And so the committee decided that once you've got more than 4 joints, so once you've had your 5th joint, they were going to put you in a separate category called extended oligoarthritis. The number 5 joints is a committee meeting decision. So when children start gaining more joints, we start thinking that they may be falling in this category, even if they haven't hit the magic number of 5. And the reason that I'm telling you that is because these children really have a very high risk of uveitis, about 1 in 2 in some case series. So we worry a lot about their eyes. So what do we do? Well, I've already said to you that treatment, early treatment, probably reduces the risk of arthritis. And if you're gaining lots of joints, we will be encouraging you to treat your child's arthritis with a systemic drug, and I'll explain what that means in a minute. And as an excellent side effect, we hope that it will also reduce their chances of getting uveitis before it ever happens. Okay, so that's oligoarthritis. So this lovely lassie sitting on her slit lamp, ready to have her eyes tested. So oligoarthritis is the highest risk of uveitis of any of the subgroups, particularly those children who are gaining joints over time. They are the youngest patients, and so the least able to tell us that they're noticing something with their eyes. And a single joint often delays their diagnosis because it's harder for doctors who aren't rheumatologists to get the right diagnosis. So I worry about these children, and we want to get them an early, rapid eye check as quickly as we can. And we'll talk about how we do that in a minute. The second group I wanted to talk about are children who have a rather different presentation. They come with a rash that looks very like this. I don't know what colour it looks on your screen, but doctors describe it as being salmon pink, so sort of pinky orangey colour. And it's a really vivid rash, and it comes on the trunk, arms and legs less often. It's more in the middle of the body. And it's associated with the child having a high fever. And any child with a high fever, doctors are obviously thinking about whether they might have an infection. And so they often come into hospital and get seen to try and work out what's going on. And they have a slightly different time. They don't go to outpatients. They're much more likely to come into hospital. And these children, again, tend to be quite young. And so, again, we really are keen to look in their eyes. Children who truly have systemic onset JIA do not get uveitis. But we always screen their eyes when they're young because we are learning that there are many diseases that look a little bit like this. And they are associated with uveitis, and very commonly at presentation. So we ask these children to have an eye check, maybe once or twice at the beginning. And then we worry the parents because we say, no, their eyes are fine, you don't need any more. And they're seeing other young children having ongoing eye checks. But the reason is that it makes us really confident that we've got the right diagnosis and that the risk of uveitis is 0 in these children. So the next group of children have polyarthritis, and poly means many. And these are children who come with many joints involved. This little girl has had jaw involvement. This little boy's got sore hands, and you can see maybe that some of these joints are here. And these children, there are 2 types of polyarthritis, and the common one in childhood is associated with about a 10% risk of getting uveitis. So these children, we screen their eyes and we look hard for uveitis as well. You can see with this number of joints, they very often get very quickly onto this systemic treatment, so treatment that's affecting the whole body to control all of the sore joints, and that again is protecting them for getting uveitis. So we get on to treating these children very quickly. We like to get an eye check in before we start treating them because the uveitis can melt away so quickly that if we leave it too long, we never find it and we never knew it was there. And that knowing that it was there can help us choose the right drugs in the future. There are some drugs we might want to avoid if we knew a child had uveitis. So we try and get an eye check in before we really crack on with treatment for these children. There are other children who have polyarthritis, and they are usually teenagers, and they are what we call rheumatoid factor positive or CCP positive, and they essentially have the same condition as adults with rheumatoid arthritis. And those children, we do not look for uveitis. It is not associated condition. It can have other eye problems, but not uveitis. And again, the children are coming much later. They are teenagers when this happens to them by and large. And so they are perfectly able to tell us about any changes in their vision. So we worry less about them not being able to tell us that something has happened to their vision. And then the final three groups of arthritis are actually all part of one big family of arthritis. So there are children who either have a parent who has psoriasis or they have some psoriasis themselves. Some children who may already have tummy problems called Crohn's disease and then get arthritis as part of that. And some children who just get the arthritis without either the psoriasis or the Crohn's disease. And we call that enthesitis related arthritis. And if you have one of these, you will probably have, there'll have been a bit of discussion with you. Maybe as a parent, you have Crohn's or psoriasis or this pattern of arthritis yourself. We would call it ankylosing spondylitis in an adult and enthesitis related arthritis in a child. And it can in adults affect the spine and the pelvic joints, but is less likely to do it so in a child that may do later on in life. And so these children, oh dear, too many buttons to press. So these children probably have about a 10 to 20% risk of uveitis. Certainly in Scotland, they seem to be about that high. It seems to be a little bit higher in Scotland than other places. So you can see that there are different types of arthritis that do carry different risks. But all of these children, we want to look for it on a regular basis and pick it up early. And it really doesn't matter which category you are in. The screening that we do is exactly the same for all of these children in the different categories. So there's one enormous difference that we spend a lot of time teaching GPs and our medical students and anybody else we can tell about uveitis in children compared to uveitis in adults. In adults, as in this young man, what happens when they get uveitis is that they get a painful red eye and they suddenly get clouded vision and can't see as well. And they may even get, do you see how this poor chap's really quite swollen around his eye as well? It's very obvious to this chap that his eye's not right. And so he seeks medical attention promptly. And that means that he gets to services quickly. In children, they are much less likely to do that. They do occasionally do that, and then families do seek attention. But for by and large, the eyes can look as beautiful as these children's pictures. They can look absolutely perfect from the outside. And there is nothing for you as a parent to spot. And there's nothing for me as a rheumatologist to spot. We need our ophthalmology colleagues to tell us that there is something going on here. So we need to look in the eyes of our youngest children, and indeed any children who have learning difficulties, who even when they get older will not be able to tell us that there's a problem, in order to make sure that we pick up any eye problems really early. And so we start with a screening program. So just to remind you, to tell you that we are aiming for perfect vision and we want to catch it really, really early. The sooner you catch it and the sooner you treat it, the better the outcomes. So we have a screening program, and there are really two things that happen in the screening program. We check that children can see with their eyes, and we do a visual acuity test, and we formally document what that is in their notes so that we can see if it's changing over time. Obviously, some children might need glasses to correct their vision, but we would usually test their visual acuity with their glasses on so that we know what their best vision is at that time with their glasses on. And for children of this kind of age, checking their visual acuity isn't difficult. It's something that children quite enjoy doing, and we can do fairly easily. But the absolutely critical test is to do a slit lamp examination. Just sticking with visual acuity for a minute, some of our patients are very much younger, so we do occasionally see children as young as 4 months presenting with JIA, and obviously in a child that is that young, we need to do special baby checks of visual acuity. Our wonderful paediatric ophthalmology colleagues are extremely good at doing that. What you can't see on this chart, but this baby with fantastic vision can, is that there are lots of vertical lines that are attracting the baby's visual gaze, and the person behind can see where the baby's eyes are going and that they are responding to the pattern on that card. So slit lamp examination. This is the absolutely critical thing that we need to do in children to make sure that there aren't subtle inflammation going on in the back of the eye that you can't see and that I can't see in the clinic. And I guess one of the issues is that the slit lamp is a big bit of medical kit. You can see this lovely girl who's maybe 3, 4 sitting on a big chair with it, and it's a big piece of kit for young children to use. They sit and pop their heads into it, and the doctor on the other side just shines a bright light in their eye, and we get good pictures. And children as young as this will often manage it. I'm just going to talk a little bit about how a slit lamp works, and then I'll come back to the younger children. So a slit lamp casts a beam of light into the eye, very much like if you've got the curtains drawn. I'm trying to get my hands on the screen, as if there's a tiny gap in the curtains and there's a shaft of light coming through, and suddenly you realize how much dust is floating around in the room. I hope you recognize that as an experience you've had. When you then open the curtains, you can't see the dust anymore. So the slit lamp is like having this shaft of light going into the eye to look to see if there's anything that's abnormal in there, looking for cells which are like dust in the inside of the eye. Whereas me or your GP with a regular old ophthalmoscope can't see that at all. It's as if the curtains are open, and we can miss the uveitis because we haven't used this bit of kit. High street opticians, optometrists will use a slit lamp, and they are often very good at it. But wriggling toddlers are not easy to see. And so we recommend that we get an eye doctor who specialises in using a slit lamp in wriggling children to have a look. So here we are, we've got the slit lamp casting light into the eye, and we're looking for the dust of inflammation, which are the cells there. And where there is more light around scattering, we just can't see that dust in the eye. So the slit lamp is the key to it. So I hear you cry, my wriggling toddler is never going to do that. That's just not going to happen. So I quite often go through to my ophthalmology colleagues with a 2-year-old that I've maybe just made the diagnosis of JIA. And I said, oh, I'm not sure you're going to get a good view of this child's eyes. They're very wriggly. I've just had great fun and games examining the joints. We've had a great time playing games in the room. And they do it. They manage to get a good view, and they are amazing. I don't know how they do it, but it's just years and years of looking in the eyes of wriggling children. So the first thing is that an amazingly high proportion of very young children, our ophthalmologists do get a good enough view that they can confidently say it's okay. There are a few children who it just doesn't work, and we maybe bring them back the next week and it still doesn't work. Usually that's at the beginning of their journey, and they've come with their arthritis. And so we are usually planning to treat their arthritis anyway. And one of the ways we often do that is with a little joint injection under anaesthetic. And so if we are planning an anaesthetic, we will also do the eye exam under that same anaesthetic. We often do any blood tests and anything else that a toddler wouldn't appreciate under that anaesthetic as well. So we try and use any anaesthetic that a child needs to have for eye exams. And even if it's a child who maybe is a bit further on and is coming back for a joint injection in the future, we might just slip in an extra eye exam under that anaesthetic because the child is still. We can really dilate up the eye, look in the back of it beautifully, measure the pressures, do all the things that wriggling toddlers don't particularly enjoy. So that's one of our options that we've got. I've already mentioned that if we start treating the eye, we've already put in a layer of protection against that. And then the other thing we do is we quite often bring that child up often and encourage you, this is where you can really help, to do some games with torches, shining a light maybe through a cardboard box, and getting the child to look at the light and casting that light across their eye with a torch, and just getting them used to it, rewarding them for sitting a bit still for doing that. And then we reward them when they come up to the clinic room. And by and large, the vast majority of children, we win this battle, and we get to see a really good view in their eyes, and the anxiety that was there goes away. But I think it can be a real worry for parents right at the beginning if their child won't sit and they're waiting for an anaesthetic to have a really good look in their eye, because you sometimes have to wait a couple of weeks, and in your head that's too long and is going to be at risk. By and large, we get an examination very quickly, and it's good. I showed you that fixed slit lamp, which is a big bit of kit. Our ophthalmologists also have these handheld slit lamps. This is, I wasn't sure to put this picture on because this little boy's chin's being held and it doesn't look very pretty, but I think he's being held gently by his mum there, and the eye doctor is getting a look in his eyes with his handheld ones. And in a slightly older girl, a slightly different style of handheld slit lamp. So we do have other bits of kit. And children with learning difficulties, again, often I had a child the other week. I wish I'd filmed it because it was great. I called in the ophthalmologist because this was a child with learning difficulties, and I really wasn't sure that we were going to get an eye screen. He walked in, he was utterly charming. We didn't do that thing of moving the child into another room with another stranger. He came to the child in the clinic and he kind of played a few games. And he was out of that room in about 30 seconds, having got a good eye exam. And I just thought, okay, they're fantastic. They really know what they're doing. So I really think that we have some options here, and by and large, we get a successful screen. So I've just put up a sort of picture of what happens here. So this is a slit lamp examination. This is what the ophthalmologist sees. They see the light as a curve as it hits this beautiful, clear outer part of the eye, the cornea. Here they have dilated the child's eyes. So the iris, the coloured part, is this tiny little brown rim around the outside, and they put some eye drops in. And this huge big area here is the child's pupil. It's been made really, really big. And what they're doing is they're looking at the black area here between the two lights. This is a part of light. And they're looking in this bit to see if there's any cells floating around or any dust, what we call flare. Which is just proteins of inflammation. The only thing you can see is this reflection of the light and this little reflection of the light. And otherwise, this is beautifully black and clear. And this is what we want to see in our screening exam. This is a perfect anterior chamber in a child. And I've got a little video in a minute to show you what it looks like when it's not normal, so you can see. Okay, so how often are we going to screen? The key point of a screening exam, no matter what your risk is that we see you often enough that, let's say you were unlucky enough that uveitis developed the day after your first screening, that by the time you came back for your next one, no damage would be done. Okay, we want this eye to be perfect, and we want to be able to completely reverse any inflammation and get the eye back to being absolutely perfect. So the intervals we have developed over time are that we do it every 2 months or 8 weekly for the first 6 months. And that interval is shorter at the beginning, partly because of little children not sitting and just wanting to have as many good views as possible. But we do think that while children are maybe starting on treatments, that they are slightly more at risk of having slightly more aggressive uveitis. So we make it slightly more frequent for the first 6 months. And again, if you stop medication that might be protecting you from developing uveitis, we tend to go back to that. But otherwise, 12 weekly, once every 3 months, we are not, we're picking things up early, and we're not getting any problems with things that we can't put right at that interval. So every 3 months is our interval. I can just hear you all going, but I've got work and 6 other children and 20 other commitments. It does seem quite a burden, I know, to be having to come up that often. Most of the sort of guidance that I'm talking about in here is based both on the Royal College of Paediatric Ophthalmologists, which is a UK-wide body of paediatric ophthalmologists, but also on our Scottish guidelines. And actually, we are more what's the word? I was going to say more aggressive, but that's not a very nice word. More diligent. We do more frequent screening in Scotland than probably some of the other guidelines that are around in different parts of the world. But in order to try and reduce that burden to you as a family, we have said that it is best practice if we can try and tie appointments together. And certainly in the bigger centres, Glasgow and Edinburgh, we've managed to do that. If you are listening in from somewhere else, you could keep on encouraging your local services to do this for you, because it really does make a difference to the amount of school a child misses, and indeed the amount of work a parent misses. So we try and have 3 monthly appointments once things are settled, where you come up, your child has their eye screen first when they're fresh and best able to sit. Then you come and see the rheumatologist and we do our bits, and then anything else that needs doing, there's an opportunity to do those while you're in clinic as well. And then you go away and you can forget about us for 3 months before you need to come back up again. So that once we've got things settled, so you maybe need to see us a little bit more often at the beginning until we've got things settled. But once things are really settled, we space those appointments out to 3 months. On clinic last Friday, I was reminded that to us means that we're doing well. A lovely 15-year-old and her dad came up on Friday. She'd had uveitis, not related to arthritis, and we'd spaced her appointments out to 3 monthly, and she assumed we got it wrong because we'd been seeing her weekly and then fortnightly, and she assumed that we must have just got it wrong. So they just came to clinic without an appointment and said, we're worried. So we did a little eye screen and showed her, and then we talked over what we clearly hadn't explained very well, which was that she was now off all the topical treatments for her eye and just on one regular medicine, and her eyes have been really good and really well and stable. And so we were confident to spread that out. And it's just a good reminder to us as doctors that sometimes we cheerfully make these assumptions, which families haven't, are really hard. It feels slightly scary to let your child go when they've had lots of eye screening appointments and risk the big gap. But we won't do it to you unless we're really confident that's an okay thing to do. So this is the structure of our service in Glasgow. So it's multi-specialist. I sit in the same clinic as my eye colleagues, which is lovely. So we have lots of rooms. There's one paediatric ophthalmologist and usually their senior trainee. So there's 2 of them sitting there. And we're also lucky enough to have a very skilled optometrist who's just a delight with the kids, and the kids sit for her really well. And she runs the screening by and large, but she has a consultant ophthalmologist at her elbow in the room next door who can pop through if she has any concerns or if she's finding it difficult. We have the rheumatology team, and what we do is we have 3 pediatric rheumatologists in that clinic at any one time. So that feeds enough patients to the ophthalmologist. They're much quicker than us to come through. We have our very important person nurse specialist. And if it gets very busy, we sometimes need more. And then we have these other people around. And we also have access to something called OCT, which I'm going to talk about in a minute. And particularly if people are traveling a long way, we try and tie in any medicines that have to be given into hospital into that clinic day as well, to be as undisrupted to families as possible. Though some families say it's too long a day and they'd rather split it, and that's fine too. We want to do what's right for the child and make life as easy for you as possible. The other thing we've done is really set up a very good system that if a child turns up at a casualty on a Sunday afternoon with concerns, that they are in our clinic on Tuesday morning seeing our eye doctors and getting that sorted out. And then we have fortnightly lists where we can have a look in the back of children's eyes, and we prioritise those children who haven't had an eye screen. So how long do we screen for? Well, it goes on for a long time. It goes on until your child is 12, and that's the start of high school. And the reason for that is that by the age of 12, we think children are old enough to pick up the subtle changes of uveitis themselves. Okay. Sometimes if your child was very, very young when they presented and never has uveitis, then we screen them for 7 years. So there are occasionally children, but they're very few and far between, who have 7 years of screening and then stop. Mostly it's we're screening till they go to high school. The risk of uveitis falls over time. You've seen that graph I showed you earlier on. So it does fall over time, but it's never quite as low as the general population. So when we discharge children from the eye screening service, we give them a few tips about checking visual acuity at home. My trick is to get them to read some very small print with one eye covered and then do it with the other eye. Not, you know, all the time, but maybe once a month on the first of the month is an easy time to remember. And the child should get, the 12-year-old by then, should get used to what their two eyes are like and tell their parents if it changes. And then to know the early features of uveitis, which I'm going to tell you in a minute, and to take up the offer of getting high street optometrists to look in the eyes. They are good and they can be very helpful. So what should you look out for? If your child has any of these at any point, share it with us and we would arrange an earlier eye check. So we're doing this 3-monthly screening, but if there are concerns, we will with great pleasure offer an extra screening so that we pick it up early. So if a child is saying that they can't see as well, particularly if they're able to tell you that they are seeing things floating in their vision or dancing spots in their vision, or that their vision is blurred, that would be a concern. That their vision is less good, or that when they're staring at bright lights, it's actually rather painful and makes them want to squint. We've all had that sensation of coming out of a very dark room into bright sunshine and find ourselves squinting. But if your child's doing that when the lights aren't as bright and they're continuing to do it for longer than you would do, then that would be a flag that would a red flag that would make us really concerned about them having uveitis. Children sometimes do just blink a bit and do funny little blinking things. If it lasts a few moments, then it's fine. But if it comes very persistent, we have had a few children that has been a sign of their uveitis. And then the obvious things, you know, if it goes red and raw and itchy and weepy, you would come because you would know that that wasn't right. That's like that's very much more like the adult with that eye that I showed you at the beginning. And even if it's not one of these, but it's just something that isn't quite right and you're worried, share it with us. I don't think we have any restrictions on eye screenings. We try and welcome, you know, families to have those. Sometimes we have families that are just very, very worried, and we may try and encourage them to space those out. But, you know, somebody who's been really sensible, been to all their eye screening appointments, and then suddenly rings up and says, you know, there's something not right, but I can't put my finger on it. You bet you'll be in, we'll do an eye screen. It's a very simple procedure. And if it reassures us all, then that's fantastic. So we're thinking about really high quality vision for our children and where we're going with this. There are a few risky times when I think uveitis is more likely to happen. If you are struggling to get medicines into your children, they're missing doses, that's a time. Or if medicines stop, or we reduce the dose, we sometimes reduce the dose. And that is a time when you're more likely to get a flare. There is one medicine that we slightly worry about called etanercept. Often your child will be having it with another medicine called methotrexate, and then their eyes are safe with the methotrexate. But etanercept on its own does seem to be associated with an increased risk of developing uveitis. If your child's arthritis is flaring, then although it may not be exactly at the same moment, in that period of time around that, then uveitis may be a little bit more likely to flare. And like arthritis, if a child gets an infection, then they may be slightly more likely to have a flare. Though that one, you know, it's not quite so prominent in the literature. So I'm back to the audit that we did in Glasgow. So let's just have a little look here. We had 40 children with uveitis and 20 of them with JIA associated uveitis. So I've just put the 20 in this out of the 209 children and they with arthritis. And we did 1,700 screening visits, okay? And out of these screening visits, these are the number of times we identified new uveitis in a child who'd not had it before, okay? So most of them happened right at the beginning. The uveitis either happened before they got arthritis or at the same first screening at the time when they first came and got their diagnosis. So that's a good chunk of the 20, about a third of children. There were 6 other children who developed uveitis who weren't on a a medicine that went right through the body, those are most likely to be children that just had a single knee, responded really well to joint injection, and we didn't feel that we needed to give them a treatment that went through the whole body, but just to watch to see if that was all that they needed. And these children, so 6 children did develop uveitis during that time, and you can see that it was in the first year, so sort of from about 4 months to about 18 months, but it was around that year mark that was likely to happen. Methotrexate is quite a good drug for uveitis, but we have seen children develop uveitis while taking methotrexate alone. And again, it was about a year after that medication started. One of the things that children do is they grow. And if their joints are fine, we often don't increase the dose. We'll leave it and let a child sort of outgrow its dose. But it may be that you know, this is what's happening here, that if we've got you on a dose of methotrexate that isn't quite enough because your child's just getting bigger and the dose isn't, then that's more at risk. This is the most important number I want you to see. Patients who were on these medicines, which I'm going to talk about in a minute, did not develop uveitis. Now, this is only a small number of visits, only 309 visits, but that is borne out by the literature from other centres as well. So these medicines not only treat uveitis, but prevent you getting it as well. Okay. And then we had children who stopped medication and their uveitis for the first time happened after they'd stopped it. And this is a child on this etanercept medicine that I was talking about. So these guys around here, the older, later children, are children that have maybe had treatment and we have stopped the medication, and that is a risky time for getting uveitis. Okay, so your child we've done screening, and very sadly you have come to an appointment and we have found that your child has developed uveitis. So what do we do? The main thing we do is that we treat it with a specific set of medications. Uveitis is part of JIA, and the same medicines that work for JIA work for uveitis. But we usually find that we need to use slightly more medicine to treat uveitis than we do to treat arthritis. So the uveitis usually drives which medicines we choose, but a big bonus of that is that the arthritis usually disappears and really doesn't cause us any problems because the eye is driving the choices of medicine. So that's a little bonus to that. So we're just back to thinking about anterior, posterior, and the bits of the eye that we want to be looking at to think about our uveitis. And I think this is my video of a slit lamp in action in a child who does have uveitis. So you can see here the pupil is little. This doctor's doing it without dilating. So this is the iris, the coloured part of the eye. And you can see the 2 lines, curved lines, and in between there are sparkles. And those sparkles are cells in the eye. But you can also see that instead of being black, it's a little bit grey, the background. And that is what we call flare. And that's because inflammation causes a little, I'll just pause this a second, causes inflammation, and so there are more proteins floating around in the eye. So instead of it being crystal clear fluid in the eye, it's a little bit hazy and it's got these cells floating around in it. Okay. In this one, they've dilated the pupil up more and there aren't as many cells. Do you see that these little sparkles here? And when they close it down, you can see a few flashes of light within the eye. Do you see them? But they're pretty subtle. That's why we get an experienced pediatric ophthalmologist to have a look and not your high street optician. And here you can see there are quite a lot of cells. I don't know off the top of your head how many you'd think that was, maybe 100, something like that. And you can see that they're floating in the eye. And so the ophthalmologist will write down on their thing the number of cells they see. And they are fussy. And so very often they will say 3 cells or 2 cells or 10 cells. So this is a really inflamed eye with many, many more cells than often we are seeing in the children. So they are being very meticulous and picking up really quite subtle inflammation. But this is much easier for you and I, who are not ophthalmologists, to see what we're talking about. Okay. You can find that video on, oh, is it going to play it again? Maybe not. On the internet as well. And these slides are going up and you can have another look at it when it's there. The next thing the eye doctor does with his slit lamp is he looks through the lens right to the back of the eye. And this amazing picture is the healthy eye of a child. It looks slightly different from an adult, but do you remember we talked about the nerve, where the nerve and the blood vessels come out? And here is that little hole with the blood vessels coming out and going across the eye. And we talked about this little dimple at the back, which is this bit here. And it's the very sensitive bit that has the very best vision in the back of the eye, the bit that you are using right now to look in the middle of the screen, looking at that picture. And nature's very clever. So instead of having blood vessels running across it and getting in the way of your vision, we have it so that there are very few blood vessels there. But that does mean it is vulnerable and that it is very delicate. And that it is relying on its blood supply with cells with oxygen moving through tissues. So it is a very delicate tissue, and it's a very important tissue. So this is what your eye doctor really wants to see at the back of the eye. And I think this is my most scary slide. It's black and white because it's an old picture, but this is a child with arthritis who had uveitis that was not treated. And you can see that very important place in the middle of the eye for vision has got damage. That means that this bit of the vision does not work as well as we would like it to. So this is absolutely what we want to prevent. And this is quite an old slide. But we have new technology. We have this thing called an ocular coherence tomography. And in children who have uveitis, we would then go on and do this test, and it's fantastic pictures. So what it's doing here is it's going for this little bit of the very important part of the vision, and it's looking at the retina in huge amount of detail as a cross section. Beautiful pictures. This is the actual, what we call the fovea, this little bit right in the middle that is the most critical. And this is a nice healthy retina. You can see that this is looking just like lines on either side. And this is a very little bit of swelling or disturbing that retina in a child with arthritis and with involvement at the back of the eye. And this is what we worry about, because the back of the eye where you see is the bit that we don't want damaged. But this is it a week later, having had good treatment. So you can see if we're picking it up on these really sensitive tests, that we can get it back to normal with good treatment very promptly. And that rapid turn off and rapid control means that we are getting normal vision and keeping it for the future. So if you look at papers that describe having this macular edema, swelling at the back of the eye, in the past we thought it was quite rare. And now we have fantastic ways of looking at it. We're finding much more subtle changes, and it looks as if it's more common, but that's because we're picking it up when it's really subtle before it's causing any damage. So we're seeing it more often, but we're treating it earlier and when it's before it's actually caused any real damage to the back of the eye. Back here in the 90s, we had children who were getting damage because we weren't able to spot it as clearly then as we can now. So here we are with our team, and in our clinics, the eye doctor makes the diagnosis, tells us what we're seeing, and the nurse works with you particularly to decide what medication is going to be the best to treat your child. Usually when we talk to parents about having treatments with medicines that go in the whole body, what we call systemic treatments, that really worries you. You've had a lovely, healthy child up to now, and suddenly we're talking about putting them on complex medicines that go in the whole body. And I think that makes you very worried. The eye doctors and the rheumatologists worry much more about just continuously putting things in the children's eyes, particularly steroid eye drops. So I'm just going to talk a little bit about why we try and get rid of those quite quickly. So first of all, I wanted to talk about assessing risk. Do you know, when we say to you out of the blue, we want to give your child some big medicines, that feels like a big risk and a big challenge to you that you have to face and make decisions about. But I suspect that you are living with risk all the time. Perhaps you drive to a clinic or drive at other times. Perhaps you sit on public transport, trains, planes, buses. What's the risk of having an accident? We all know that cars have accidents. We all wear our seatbelts. We all get our cars MOT'd. We all use the highway code. And we all live with that risk because it's one we've got used to. And I think that thinking about medicines is a bit like that. It's a completely new concept to you about thinking about your child and this particular medicine. And so it seems a huge risk. What we need to do is explain to you that medicines, like having a car and like having a seatbelt and an MOT, are things that we can reduce the risk of side effects. And like road traffic accidents, they happen, but they're not that common. And the medicines we use do not have that common side effects. So we tell you all the side effects, and I think we're probably the world's worst car salesman. If you went in to buy a new car and the car salesman said, yeah, you can have a car, but you might just have a road traffic accident. Terrible things happen in road traffic accidents. They wouldn't get very far. Doctors are the world's worst car salesmen. We tell you all the side effects of our medicines, but we don't put it into the perspective of the risk benefit of the eyes, or the joints indeed. And we would never offer a drug if we thought that the risks outweighed the benefits. And the medicines we use are proving safe over time. And so we take you through some of those side effects at the beginning so that you know about them and look out for them. But I think that by and large, we are seeing children tolerating many of the medicines well. One of the medicines they do struggle with the most is methotrexate, and we have things beyond methotrexate that are in some ways easier to take. So topical steroids, I said this is what we worry about. Steroids are a fantastic medicine for setting inflammation. They are really good at settling inflammation. They do it quickly and they do it effectively. But if you then stop them, then the inflammation tends to come back. And steroids, however you give them, whether you put them in the eye or you give them into the whole body, can have side effects that we want to avoid if you keep giving them over a long period of time. And children's eyes are particularly delicate, so adult ophthalmologists will often use topical steroids for a long period in adults, and in children we are very clear in our guidelines that we need to get away from topical steroids because of those side effects. And there are two side effects. If you leave uveitis untreated for a long period of time, it can damage the lens and cause a cataract, and it can put the pressure up in the eye, which is what we call glaucoma. But steroid in the eye can also cause cataract and glaucoma. So we settle the inflammation, but we are still getting some of the side effects that we didn't want. So this leaves us between the devil and the deep blue sea, and we want to get away from topical steroids as quickly as we can. I think I probably said this, that the cataract is the clouding of the lens. It can be caused when there's a lot of inflammation around, but steroid also can cause it. And glaucoma, when there's a lot of inflammation, it clogs up these drainage holes I was talking about. And so it can raise the pressure inside the eye, but also steroids can do that. So back to my audit, I wanted to take you through some of the information we've got from that. And there's plenty of other literature around that is saying the same thing. So if we think about topical steroids and the pressure in the eye, so pressure more than 20, we begin to get worried, and a pressure more than 25, we would call raised. You can see that children who are on topical steroids have really quite a high 82% chance of having raised pressure. Children who have uveitis and steroids have got a 57% of them had raised pressure. Children who had just active uveitis but no topical steroids, that fell to a 10% risk. Yeah. And children without topical steroids in this group with active uveitis, it was 17% overall. So you can see that steroids are a really important cause of raising the pressure in the eye, and one that we really, really want to get rid of. So we use them as a quick rescue treatment, and then we try and persuade you to move on to systemic medicines to get rid of those topical steroids. A bit like having high blood pressure. If you have it for a very short time, a high pressure in the eye doesn't do any damage. But if you leave it for a long time, just like having high blood pressure for many years, it can damage the eye. So short, sharp shot with steroids to treat the inflammation is okay, but longer term is a real concern. And cataract and steroid. So we have only 4 children with cataract over the course of the audit, and 3 of them had already got early changes of cataract when they came. and one did develop cataract during their care. And they were a family who, after 4.5 years, were still saying they didn't want the treatment systemically, and they had repeated flares of uveitis and repeated courses of topical steroids. So that family ended up with a child who did have a cataract. We could pick it up at an early stage, and we changed the treatment plan, and at that point we did manage to get them on systemic treatment to stop that cataract getting any worse. So the medicine plan from us will be rapidly control that inflammation in the eye, either with eye drops or with a systemic steroid if we're really worried. Occasionally things are so mild, 2 or 3 cells in there, that we can just start a regular systemic medicine without needing any steroids at all. And then once we've got it under control, we keep it away with our systemic treatments. Just before I finish on topical treatments, you may be asked to give other drops. One of them is something to open up that pupil. If you leave the pupil very closed in a very sticky, inflamed eye, it can get stuck. So we dilate it to stop it getting stuck. And that's only a temporary measure until the inflammation's gone. And if a child does have high pressure in the eyes, we would give eye drops to settle the pressure and improve it. And again, that's a temporary thing until steroids are gone. So those are the only other 2 topical treatments we regularly use. Right, the mainstay of our treatments. There are 2 main groups. One are disease-modifying anti-rheumatic drugs. We call them DMARDs for start. For short, and the main one of those is one called methotrexate, and it is good for uveitis. It's also very good for arthritis, so that would be our usual first choice because it's treating both the eyes and the joints. If a child just has uveitis, we might use this thing called mycophenolate mofetil, which we also call MMF. And leflunomide is a bit like methotrexate, and we sometimes use that as an alternative. But mostly we offer methotrexate, and if a child, either it isn't working well enough for their uveitis or indeed their arthritis, or if they just can't tolerate it because it's a hard drug to take sometimes, then we would offer to move you on to biologic treatments. Biologic treatments have been around since about 2000 in regular clinical use, and a little bit before that in clinical trials, but methotrexate's been around since the 1950s. I think when we first started with biologics, we were all a bit worried about it. I can tell you that one of the really lovely things that happened is that patients we had been struggling with DMARDs, including some that we don't use anymore because they really are quite difficult for children, were offered these new medicines, and a number of my colleagues were in tears. They were in tears because children they had struggled and struggled to treat their arthritis, who'd been sore every time they came to clinic and stiff, came running in 3 or 4 or 5 or 6 months after starting these new medicines, saying, look at me, I can run, I can walk. And it was just magical. It was these drugs are fantastic. And our trainees coming through now have never seen children with poorly treated arthritis because we have these wonderful medicines. And the number of children who were having vision loss with uveitis was high at that time as well. And again, that is disappearing and becoming something of the past because we have these wonderful medicines. So we are looking at them in clinical trials, and they're proving their worth there. And there are one big group, the anti-TNFs, which are our first choice. And there are 2 big drugs in that, adalimumab and infliximab. Golimumab is it's a slightly newer preparation, and we just have less experience with it. And doctors are creatures of habit, and we know these 2 well. But in the few patients where this has been a better choice for a patient, where we've been really quite encouraged that it seems to be working well. There aren't huge trials in children with this yet, but there are good case series of 10, 20 patients in a case series showing that it's okay. The one we don't use is etanercept, because actually we've learned that anti-TNF, it's a different structure to the drug, and we learned right at the beginning that unfortunately it can precipitate uveitis, so we would never use it to treat uveitis. There are some other biologics that we use to treat uveitis, but you'll probably be offered these first unless there are good reasons to think about some of these other treatments. So these are our top treatments. And some of you who have had children with arthritis for a long time may indeed been invited to take part in one of the trials that showed how good adalimumab was. At this point, there really is a choice for you. The choice between these two, they're both as good as each other. We have never done a head-to-head trial in these two, and we would need huge numbers of patients to prove that there was any difference between these two medicines at all, because they're both proving that they're extremely good. So we would literally need hundreds and hundreds of children to show whether one was slightly better than the other. So they really are both excellent. So you have a choice, and actually the choices are about what suits your child. So adalimumab is an injection given into the leg subcutaneously on a fortnightly interval. And adalimumab, you come into hospital and your child has a little drip put in, and we would have it as a drip given through that, usually at 8 weekly intervals. But if we need to give it a bit more often, then we can make that 6 weekly or 4 weekly intervals. Both of them, because they are antibodies, that's what the MAB means, they're monoclonal antibodies, your body will react to them and try and clear these away. And you will actually end up rejecting these medicines. So in order to stop your child doing that, we give a co-med. And that co-med is usually a DMARD, and it's usually something that will also treat either uveitis or arthritis at that point. So those are the kind of choices we have. But your nurse specialist can take you through why one drug might be better than you, one drug might be better for your child than another, and also the different preparations, particularly for this one that you're doing at home, which one is best for you and your child. So there's real choice there. So once we've done this, we can come to the co-meds. Methotrexate's a perfectly good co-med, but often the reason we're moving on to this is that children find methotrexate a hard medicine, and so we would maybe use some of these other things as co-meds. And mycophenolate's good if you've got uveitis, because it's very good at treating uveitis. It's not quite so good at treating arthritis, but these guys are. So you've got a medicine for your arthritis and a co-med that backs it up for your eyes. We're happy to adapt this to, different age children. Things may be better at different ages, and things may change over time as a child gets older. So what's right for a 2-year-old may be different from a 6-year-old, maybe different from a 15-year-old. But we do have to be mindful that this is not an infinite list on this slide. There is a limit to what we've got, and what we mustn't do is work through them all just for frivolous reasons. And a child who maybe does need medicine ongoing, find that we're sending them to the adult service without a lot of choices of what they're going to need. So we need to just be mindful not to use up these for frivolous reasons, but we absolutely can adapt the choices to suit your child and any difficulties your child is having with medicines. We may not have a perfect option for you, but we can give you options and we can try and make the best decision. So what should you expect? Regular eye screening, no more than 3 monthly, up to the age of 12 years. Rapid access to screening if you've got any concerns, and your best route in is usually through your nurse specialist, not through your eye doctors, because often the junior doctors are changing all the time. Better to go to your nurse specialist and the rheumatology team. You can expect a topical treatment or to settle the eye inflammation very quickly if it starts at the beginning, but we will then be twisting your arm to have a longer term medicine that we give into the whole body, and then we're not putting anything into the eyes on a longer term basis. And how long are we going to treat for? Well, we don't know the answer to this, and actually I think the answer is that some children have disease that is going to go on into the future, and some children it's a short-term thing. And they can stop treatment and do very well. But we don't have a good test, and we don't have a crystal ball to tell us which children are which. So what we normally offer is that from the day that the eyes and the joints are perfect, we start the clock and we carry on with treatment for 2 years after that. And at that point, we offer the option to stop medicines. If that's at a terrible time for you as a family, then you may say that actually you'd rather stay in a good disease control. Let's say a child's competing at a high level of sport, or is about to go to high school, or is in the middle of school exams. That might be a terrible time to risk stopping medicines, and it might be better just to leave it a little bit longer. And what we warn you is that you have to be prepared for a disease flare. That might happen within a few weeks of stopping medicines, or it might be that you go for 2 or 3 years before anything happens, but that it does come back in the end. So we warn you that that might happen. And for a small number of children, probably about 40%, they will do well and they will get off medicines for a long time or forever. But for many children, if you've got uveitis, it may come back and it's telling us that you may need ongoing treatment. Some families don't want to wait as long as 2 years and try and come off medicines before. Some families will try having a break from treatment on more than one occasion to see if they're luckier the second time. That's fine. As long as we're watching things carefully and catch them early, if it does come back, then no harm is done. And actually, I think for young people, it's often, if they have been taking a medicine for a long time and their disease comes back when they stop it, then they understand that they were taking it for a good reason. A child who's been well for a long time often doesn't really remember why they're taking their medicine. Their parents may, but they may have long forgotten why they were taking it. So that can be a useful thing to do for everybody. So my last couple of slides. We have good guidelines in Scotland. We update them, and I'm just updating them at the moment to really set the highest standards and the highest expectations for eye outcomes. You can find guidelines that are UK-wide on things like the BSPA website, and you can find our Scottish guidelines on the SPAN website. Your care can be provided in your local services, and I am very keen that things like access to OCT are available in every single clinic. I don't think that's true that it's available in absolutely every clinic yet. So ask your local service and encourage them to try and get it. It's a fairly routine in adult ophthalmology services now. One thing I'm very keen is that we do, and you've seen I've given you a lot of slides with it, is that audit, going back and looking what happened to your patients, is a very powerful way of working out what you could do better. And you may not have spotted it as you're going through. It may only become apparent that there are some things that you could do better when you look. And I'm really keen. One of the things I've not succeeded in doing is getting all the centres across Scotland to perform an audit. And I'm very keen that we encourage all our services to perform audit of their outcomes, so that if there are services where things are harder, the audit we did looked at the time interval for screening and whether that was possible to provide, and all those sort of other variables that we can put input in where it's harder. We can actually invest where we need to. And damage is unusual, and if it does occur, it's usually something we find the very first time we get a look in your child's eyes, rather than something that happens over the future. So if you do meet children with eye damage, they had disease that was before we had good treatment, and there are a few of those still in the service, so they're going to adult services as they're getting older, or it was there on the day that we first met them. So what are the things I think we need to do? We need to get our patients to us earlier. If we get them earlier, then we'll see less damage because we're catching this earlier in the process. And I've talked about topical steroids being a concern, but there are good news. We're seeing less uveitis. We're not seeing cataract and glaucoma and needing to treat that in a difficult way. Surgery for glaucoma in children is something, again, that is just in the past. We've not done that in Glasgow for a long time now. And we're better at picking up macular edema, catching it early and treating it more aggressively. And we maybe are seeing more uveitis later, but that's because we've stopped it happening early because of treatment, and then it's coming when a child's older. And our visual outcomes for children are good, are really good. We're getting children with perfect vision as our main outcome. So I've probably talked for massively longer than I should have done, because I've realised it's a Zoom thing that you just chat away to a blank audience. But I'm going to stop sharing and encourage you to turn your cameras on and encourage you to ask lots of lovely questions.